You have had blood tests, probably many of them. Every year, sometimes more often, a needle goes in, a vial comes out, and a few days later, a number appears on a report next to a reference range. Normal. Everything looks fine. Your doctor glances at the results, nods, and moves on. And you leave believing your kidneys are fine. Here is what that blood test is not telling you. The standard kidney markers on a routine blood panel, creatinine, and the estimated GFR calculated from it, have a fundamental limitation that has been known in nephrology for decades and discussed almost nowhere else. They do not detect kidney dysfunction until a significant portion of kidney function has already been lost. Not a small portion, a significant one. By the time creatinine rises enough to push your GFR below the threshold that triggers clinical concern, you have typically lost between 40 and 60% of your kidney's functional capacity. 40 to 60%. Before a single number on your annual blood panel raised a flag. This is not a flaw in your doctor's attention. It is a flaw in the test itself. And it exists because creatinine is a crude and indirect measure. It is a waste product of muscle metabolism that the kidneys clear from the blood. When kidney function begins to decline, the remaining healthy kidney tissue compensates by working harder, maintaining creatinine clearance at near normal levels until the compensation can no longer keep pace. The blood test sees normal. The kidney is not normal. And the gap between those two realities is where years of preventable damage accumulate undetected. There is a test that closes this gap. It has been available for over 2 decades. It is more sensitive, more accurate, and more predictive of kidney disease progression than creatinine at every stage of early dysfunction. Multiple major nephrology organizations have recommended its broader adoption in clinical practice. And it remains almost entirely absent from standard annual blood panels because ordering it requires a specific awareness that most general practitioners were never trained to apply routinely. The test is called Cystatin C, and by the end of this video, you will know exactly what it measures, why it outperforms creatinine in detecting early kidney dysfunction, who needs it most urgently, and precisely what to say to your doctor to get it ordered at your next appointment. But that is not the only test on this list. There are 4 others that nephrologists use to see what standard panels consistently miss, and the most revealing one, number 1, is not a blood test at all. It is something you can collect at home, costs almost nothing to analyze, and tells the kidney's story more completely than any single blood marker available. Before we begin, tell us in the comments right now, when was the last time your kidney function was tested? And did anyone ever explain to you what your GFR number actually means? Drop it below. We read and respond to every single comment. Number 5, red blood cell magnesium. Most doctors who test magnesium test it the wrong way. This is not a criticism. It is a structural problem in how the test is ordered and what the result actually represents. Standard serum magnesium measures the concentration of magnesium in the liquid portion of the blood. It sounds like a reasonable proxy for overall magnesium status. It is not, for one specific reason. The body stores only about 1% of its total magnesium in the blood. The remaining 99% resides inside cells, in bone, and in muscle tissue. The body defends serum magnesium levels aggressively, pulling magnesium from cellular and bone stores to keep blood levels normal, even when the body is significantly depleted overall. A serum magnesium test can return a perfectly normal result, while intracellular magnesium is critically low. This matters directly for kidney health because magnesium is required for the enzymatic conversion of vitamin D from its inactive storage form into its biologically active form, for the regulation of calcium metabolism, for the maintenance of normal tubular cell function, and for the hormonal systems that govern kidney blood pressure regulation. When intracellular magnesium is depleted, all of these processes are compromised simultaneously, and the kidney bears the cumulative burden. Red blood cell magnesium, by contrast, measures magnesium inside the red blood cells themselves. This is an intracellular measurement. It reflects what is actually available inside cells for metabolic function, and it catches deficiencies that serum testing consistently misses. A 2019 study published in Nutrients found that among adults whose serum magnesium was within the normal reference range, 38% had red blood cell magnesium levels indicating clinically significant intracellular deficiency. More than 1 in 3 people who would have been told their magnesium is fine by standard testing were actually deficient by the more accurate measure. And every one of those deficiencies was silently compromising the kidney processes that depend on intracellular magnesium to function. When you ask for this test, ask specifically for RBC magnesium, not serum magnesium. The distinction matters, and if you do not specify, you will almost certainly receive the less informative version by default. Number 4. Urine protein to creatinine ratio. Protein in the urine is one of the earliest detectable signs of kidney filter damage. When the glomerular membranes are healthy and intact, they retain large molecules like albumin in the bloodstream, while allowing water and small waste products to pass through into urine. When those membranes begin to be damaged, protein leaks through. Detecting that protein early is the difference between catching kidney disease at a stage where intervention is most effective and discovering it years later when the damage has compounded. The standard urinalysis dipstick test that appears on most routine panels detects protein in urine only when it exceeds a relatively high threshold. Low-level proteinuria, which is the stage at which kidney filter damage is most reversible, passes entirely below the dipstick's detection limit and appears as normal on the standard panel. The urine protein to creatinine ratio is a far more sensitive measure. It detects protein leakage at levels the dipstick misses entirely, and it provides a quantitative result that can be tracked over time to determine whether protein excretion is stable, improving, or worsening. This trajectory information is clinically invaluable in ways that a simple positive or negative dipstick result cannot provide. A 2020 paper from the National Kidney Foundation reviewing detection rates across different testing methods found that the protein to creatinine ratio identified early-stage proteinuria in 41% of adults who had tested negative on standard dipstick urinalysis in the preceding 12 months. 41% of people with detectable kidney filter damage who had been told their urine was normal. The test existed, it was not ordered. This test requires a urine sample, not a blood draw. It can be ordered as a spot test on a single urine sample collected at any time of day, or as a first morning collection if greater precision is needed. Ask for it by name at your next appointment. Urine protein to creatinine ratio, or UPCR. Before we continue, if this has been useful so far, hit that like button so more people can find this information. Subscribe and turn on notifications. New content every week. Number 3. FGF23. This one is less familiar, even to many general practitioners, and it represents the frontier of early kidney disease detection in current nephrology research. FGF23, or fibroblast growth factor 23, is a hormone produced by bone cells in response to elevated phosphate levels in the blood. When the kidneys begin to lose filtration efficiency, one of the earliest metabolic consequences is a subtle rise in blood phosphate, too small to push phosphate itself outside the normal reference range, but large enough to trigger increased FGF23 production as a compensatory response. The body is attempting to force the kidneys to excrete more phosphate before blood levels rise visibly. This means that FGF23 rises before phosphate rises, which means that FGF23 elevation is detectable at an earlier stage of kidney dysfunction than any phosphate measurement. It is a leading indicator rather than a concurrent one. A landmark study published in the Journal of the American Medical Association followed adults with early-stage chronic kidney disease for 5 years. Elevated FGF23 at baseline predicted progression to later stages of kidney disease and cardiovascular events, with greater accuracy than any other single biomarker tested, including creatinine, GFR, and phosphate. Adults in the highest FGF23 quartile were 2.6 times more likely to experience significant kidney function decline during the study period. FGF23 testing is not yet a routine recommendation for all adults. It is most relevant for those who already have a documented reduction in GFR below 60, those with significant cardiovascular risk factors alongside early kidney concerns, and those who have been using high-dose vitamin D supplementation for extended periods without concurrent K2 and magnesium support. In these populations, an elevated FGF23 can change the clinical management approach in ways that standard testing would not prompt. Number 2, Cystatin C. This is the test that should have replaced creatinine-based GFR estimates in routine clinical practice years ago, and the research behind that argument is overwhelming. Cystatin C is a protein produced by virtually every nucleated cell in the body at a constant rate. It is filtered entirely by the glomeruli of the kidney and is neither secreted nor reabsorbed by the tubules. This makes it a near-ideal marker of glomerular filtration rate because its blood concentration reflects filtration efficiency directly, without the confounding variables that make creatinine an imprecise measure. Creatinine production varies with muscle mass. An older adult with significant muscle loss will have lower creatinine production regardless of kidney function, meaning their creatinine-based GFR estimate will appear better than their actual filtration capacity. This phenomenon, called creatinine-based GFR overestimation in sarcopenic adults, is extraordinarily common in adults over 65 and leads systematically to underestimation of kidney disease severity in exactly the population at highest risk. Cystatin C does not have this problem. It is produced at a constant rate independent of muscle mass, sex, and body composition. Studies comparing Cystatin C-based GFR estimates to creatinine-based estimates in older adults consistently find that Cystatin C identifies kidney dysfunction at earlier stages and predicts clinical outcomes, including progression to kidney failure, cardiovascular events, and mortality, with significantly greater accuracy. A 2012 study published in the New England Journal of Medicine, examining data from over 3,000 adults, found that reclassifying patients from creatinine-based GFR to Cystatin C-based GFR changed the risk category of 19% of participants, almost all of them moving into higher risk categories that the creatinine estimate had missed. 1 in 5 people whose kidney function appeared adequate by standard testing was actually at meaningfully higher risk, detectable only with the more accurate marker. The test is widely available. It is covered by most insurance when ordered with appropriate clinical justification, and ordering it requires only that a clinician write it on the lab requisition alongside or instead of the standard creatinine panel. Ask for it by name, Cystatin C GFR, or eGFR-CYS. If your doctor is unfamiliar with it, the description of a more muscle-independent measure of filtration rate will be immediately recognizable to any clinician with nephrology training. Number 1. A first morning urine albumin to creatinine ratio. The most revealing kidney test on this list is not a blood test at all. It is a urine test, collected at home from the first urination of the day, analyzed in a standard laboratory for less than the cost of most blood panels. And it provides a window into kidney filter integrity that no blood marker can match for sensitivity at the earliest stages of damage. Albumin is the primary protein that healthy kidney filters are designed to retain. When glomerular membranes are intact and functioning normally, albumin stays in the bloodstream where it belongs. When those membranes are being damaged, albumin begins to leak into urine in amounts that are initially too small to affect blood albumin levels, too small to elevate creatinine, and too small to trigger a standard dipstick positive result, but entirely measurable with a sensitive quantitative assay. The first morning urine is used specifically because it is the most concentrated urine of the day, having been produced overnight, during the period of lowest fluid intake and highest antidiuretic hormone activity. This concentration maximizes the detectability of low-level albumin leakage. A microalbumin test on a random daytime urine sample can miss what a first morning sample catches reliably. The albumin to creatinine ratio, expressed as milligrams of albumin per gram of creatinine, accounts for the variable concentration of the urine sample, giving a result that is comparable across collections, regardless of hydration status. A ratio below 30 milligrams per gram is considered normal. Values between 30 and 300 indicate microalbuminuria, the earliest detectable stage of glomerular filter damage. Values above 300 indicate macroalbuminuria, representing more significant membrane disruption. A 2018 study from the Chronic Kidney Disease Prognosis Consortium, pooling data from over 1.4 million adults across 45 cohorts, found that microalbuminuria was the single strongest independent predictor of kidney disease progression available from any routine test, outperforming GFR, creatinine, cystatin C, and every blood biomarker examined when measured at the earliest detectable stage. Earlier detection, more predictive, less invasive, collectible at home. A woman came in whose creatinine and GFR had been entirely normal on every annual panel for 7 years. She had no symptoms, no diagnosed conditions, and no reason anyone had identified to look more carefully. She came in because she had read about first morning urine testing and asked specifically for it. Her albumin to creatinine ratio was 67 milligrams per gram. Microalbuminuria, early glomerular damage, detectable, addressable, with 7 years of normal blood tests sitting in her chart beside it. Her blood pressure was adjusted. Her dietary protein distribution was optimized. Her NSAID use, which had been occasional but regular for joint pain, was replaced. 18 months later, her albumin to creatinine ratio had decreased to 24, below the microalbuminuria threshold. The damage had not progressed. In some measurable respects, it had partially reversed, because the test found it early enough to change the direction. 5 tests, none of them exotic, none of them requiring specialized equipment or hospital access. All of them available through standard laboratories, orderable at a routine appointment, and capable of revealing what years of normal creatinine results have been concealing. Write down these names before your next appointment. Cystatin C, first morning urine albumin to creatinine ratio, urine protein to creatinine ratio, RBC magnesium, FGF23 if you have existing cardiovascular risk alongside kidney concerns. Explain that you want a more complete picture of kidney function than the standard panel provides. Any clinician with nephrology awareness will recognize exactly what you are asking for and why. The window in which early kidney damage is most reversible is the window in which standard testing sees nothing wrong. These 5 tests open that window. What you do with the view is the part that determines what the next decade looks like. Now we want to hear from you. Did you know any of these tests existed before today? Has a doctor ever ordered any of them for you? Share in the comments below. We respond to every single one. Subscribe if you haven't already. Next week, we are covering the 7 physical signs your kidneys are already struggling, visible on your skin, your feet, and around your eyes, long before any blood test shows a problem.